Thanks. Okay, so welcome everyone. Cicely will be joining us in about 20 minutes or so, but we'll get started and hear from all of you folks from Turning Point. It's great to be together. I think be good for us all to introduce ourselves, since I think there are some folks on the screen who probably haven't been with each other yet. And I'm Eleanor Revelle. I'm the council member for the 7th Ward here in Evanston. And maybe we'll start with our committee. Angela, you want to introduce yourself?
Sure. Hi, I'm Angela Valavanis. I'm a business owner here in Evanston called Creative Co-working, and I'm also on the board of directors for the Evanston Chamber of Commerce and the Downtown Evanston organization.
Great. Kristen?
Hi everyone, I'm Kristen Kennard. I'm the Deputy Director and the Director of Social Work Services at the Moran Center in Evanston.
Patty?
Hi everyone, I'm Patty Capucci, the Executive Director of Impact Behavioral Health Partners in Evanston and expanding out into Skokie sometime soon.
Great, yep. James?
Good afternoon, everyone. I'm James Barnett. I'm a Community Programs Manager at Connections for the Homeless.
Great, okay. Indira, do you want to say hi?
Sure. I'm Indira Perkins. I'm the Human Services Manager in the Health and Human Services, and I just provide tech and any help behind the scenes.
Great, okay. And here's Maureen. You want to introduce yourself, Maureen?
Sorry, Maureen McDonnell, Executive Director at Peer Services.
Great, okay. And then, so Anne, why don't we turn it over to you and the Turning Point folks here to introduce themselves.
Thank you. I'm Anne Raney. I'm the CEO at Turning Point. Noy and Dan.
Hi everyone, I'm Noy Freya Lopez, Chief Clinical Officer at Turning Point.
Good afternoon, everyone. Dan Wasmer. I'm a consultant to Turning Point.
Great. Okay. So Anne, we chatted with you, gosh, back in June, I think it was.
I think so.
Before you heard about the grant possibility. So you want to bring us up to date on what's been happening at Turning Point and how we can be partnering to help with what you're going to be doing.
Sure, I'd be delighted. Thank you. I really appreciate this invitation to propose how Turning Point might address mental health crises in Evanston. You know, we're members of a very strong community of providers in the Evanston area. And with that in mind, I'd like to propose that we each do what we do best. So I have 3 ideas that I'd like to share. The first one is, when it comes to doing what we do best at Turning Point, one of our programs is our living room program. So we would like to open at least one living room facility at an easily accessible location in Evanston. I want to tell you a little bit more details about our program. And just to explain, Noy is our Chief Clinical Officer. He oversees all of our clinical programs. Dan Wasmer is a longtime friend of ours from DMH and knows our living room program very well. Some of you have heard about this new program called 590. We've been funded to provide expanded services, including the community of Evanston, and Dan has been a point person on that project. So I'll do the presentation, but when you have questions, it may well be that one of my colleagues can answer them better than I can. So let me tell you a little bit more about our program. We will celebrate our 10th anniversary in September. And since we opened the living room at Turning Point, we have a 99% success rate at helping adults in crises avoid a trip to the emergency department or to be involved with police. These efforts, of course, have resulted in fewer calls to first responders, but they've also allowed our guests, and that's what we call the individuals who come to the living room, to return to their homes once their crises have lessened. So they're able to go back to work, to care for their families, and to avoid an expensive and unnecessary trip to a hospital or a police department. Our staffing is anchored by recovery support specialists, and these are adults who are themselves in the process of recovery from mental illness. They anchor our program, they share their experiences, they problem solve, they're living what our guests are experiencing. When a guest arrives at our living room, they determine a SUDS score, and SUDS stands for Subjective Units of Distress Score. And that's the quantitative way our guests determine the level of distress they're in, and then they repeat that score when they leave our living room. So that's one of the ways that we keep track of the progress that we make with our guests. We also are very careful to hear what the guests say has helped them during the time they spend in our living room. And guests are allowed to spend as much time as they need in our living room. Generally, the average is around a couple of hours, but no one is pushing them to leave. And I think often there are conversations with our recovery support specialists, and then the guest goes and sits and thinks a bit, or maybe watches TV, or rests in a quiet room that we have, or browses the web. And then may come back and check in with the peers before they go home. Some of our guests even go out with a report card, which is a little index card or piece of paper that summarizes what has been helpful that day, so they can refer to it later if they feel anxious or upset. The modalities that we offer in the living room include cognitive behavioral therapy, dialectic behavioral therapy, motivational interviewing, mindfulness, yoga, and all kinds of measures that our peers have found helpful and that our agency provides as a matter of course in its clinical programs. And I'll be glad to answer questions about those modalities later, but I really want to emphasize that we're not simply welcoming someone into a friendly conversation and a reassurance of support. We're actually providing knowledge-based practice that actually has resulted in resolution of crisis. So if a guest needs to access a computer to look up information for a job search, we have a resource center that is adjacent to our living room. And we also help guests apply for Medicaid benefits or other services that will provide important means of support for them and their families. Let me tell you a bit more about our history and our commitment. We are an active member of a group of living room providers that NOI founded some years ago now. They have living rooms all over the Chicagoland area. And we welcome those people who come together to share lessons learned and things that we wish we had known before, and resources that can support good work. We also have presented a series of peer academies at Turning Point, where organizations who either already have living rooms or are thinking about beginning a living room program can come and learn about how to set up a living room, how to talk to a board of directors about a living room, how to staff a living room, how to support the peers, the adults who are in recovery, and how to establish and maintain community relationships, because engagement and community awareness is a really important pillar of our living room program. If people don't know about the program and don't know how to get there, it's not very useful. And more than half of our guests in the living room at Turning Point have no other affiliation with Turning Point. So it's not our clients who are coming to the living room. It is also people who have heard of us, who are referred to us by hospitals or police or the library. We have some very strong relationships with our community, and they can refer people to come and meet at Turning Point. So we're proud of what we do, and we're eager to share what we've learned. And what we need is an accessible location. And what you can expect from us is 10 years of experience and enthusiasm and a willingness to learn more specifically what Evanston needs and how we can design a living room that meets our community's needs. And I'm a proud member of the Evanston community. So just want to make that clear. One more benefit that I want to mention, a living room in Evanston could serve as a point of intake for adults with other needs that might be met by collegial providers. For example, individuals with substance abuse issues could be immediately connected with peer services, as well as persons with work or employment concerns could be immediately connected with impact services. We've already made a commitment to establish this single pathway to care for our Skokie-based program, knowing that this response to crisis could be life-changing. And I just want to emphasize this. I think when people are in crisis, it's whatever they feel is crisis for them. It could be a family matter, it could be a job loss, it could be a death of someone, it could be an illness, it could be a diagnosis. And one of the things that's really rich about our community of collegial providers is that we're all trying to help one another and to help people most directly and most quickly. So we have made a commitment in our Turning Point programs at Skokie to work right now with peer and impact to get people directly into care so that if they have to wait to see a therapist at Turning Point, they don't have to wait to see someone at peer or at impact. Depending upon what our census is, we can serve people as soon as possible. Nobody else is doing this. It's pretty unusual to break through the silos and begin to share in this way. But one of the things I really want to emphasize is that we have very close and creative relationships with our community providers. We've been talking with Peer and Impact and Connections and Trilogy for a number of months about how we can serve our communities better. We talk about how we might work together to develop programs that lead to efficiencies and effectiveness. And Evanston is a key location for us. We've known one another for many years, but in the last few years, Maureen and Patty and I have been meeting, Noy has been meeting with the staff that I mentioned earlier. And another thing I want to emphasize is that at our Turning Point building in Skokie, we're very happy to have tenants who really enrich our environment. So NAMI, Cook County North Shore is a tenant in Evans at our Skokie location. Mental Health America is a tenant. We have a Heartland Health Center at Turning Point in Skokie. Impact staffs an office daily where they work with our clients on workforce issues. And next month, we'll have a big welcome party for Peer because they will be taking some offices in our Turning Point building. So I really, it's very important for me to emphasize to you this sort of openness and willingness to be involved with one another. Turning Point is one of many organizations who want to find new ways to serve our communities. But I think we do it with a very deep commitment and skill and compassion. We believe in sharing, not silos. We have a long history of working with other people. And your decision to support the establishment of a living room in Evanston could be a major piece of a pilot project that could join, for example, Trilogy, who has such a great expertise in mobile crisis response, with Turning Point's living room program. We're already friends. We already work closely together. We do not overlap so much in terms of services. There's very little competition between us. We're geographically distinct, but we have a lot of synergy among our staff and our programs. And I think there's huge potential to do something that could make Evanston really proud and could show the state that we can do things differently. So I'm very excited about this. I hope that you'll consider this proposal. I think it can result in an effective pathway to care that will reduce reliance on 911 calls while really improving outcomes for persons served. And last but really not least, can help us all learn from one another about how we can do our work better.
So Anne, you said you had 3 asks for us? And this is the first one,
Well, actually, I just wanted to share 3 ideas. So the first was staffing. The second was working together. And the third was that I think we can do something new and very, very innovative in Evanston.
Okay, great.
No more requests. Just the one.
Okay, great. So committee members, do you have questions or comments? Or yes, Angela.
Can you tell us a little bit more about, you called it the Peer Academy, of learning how to set it up, and like how long you usually work with someone to do that kind of training?
Sure. We've offered it as a 1-day training so far, and it's sort of like a school day. So there are modules that include talking to your board of directors about what a living room looks like, talking about budgeting for a living room, talking about what you need to have in order to set up a living room in terms of bricks and mortar and stuff. But another very important part is, how can you support people who are living with mental illness in these very important, I call them anchoring roles, because some of these individuals have very stable recovery lives and they work day in, day out, but others sometimes have a relapse or have something come up that makes it difficult for them to do their jobs. So generally, there are quite a few people on a peer staff. Another issue that many of our peers share is that they have benefits that they're receiving which keep them from working full time. So there are some important points around working with peers, but we also really want to encourage people in recovery to consider being peers. So another module on this day is our peers talk about what their jobs are like, and they try to inspire people to consider becoming a peer. And there is a certification called a Certified Recovery Support Specialist that is offered in the state of Illinois for these individuals so that they can get some more training. And working with peers is really a blessing and something that has taught us so much about the work that we do. They're full members of our staff, but it's a unique kind of program. And so these peer academies are designed to help somebody come away either with some tools that they can use, or some ideas about starting a program, or some recommendations for us about what we could do better.
Great. Other questions and comments? Kristen? Yeah.
Can I just ask a really basic question? What hours are your living room open and days?
We're open from 12 noon until 8 p.m., 7 days a week. And those hours, Kristen, are really determined by funding. So, the more funding, the more hours. And this year we were able to move to a 7-day-a-week, 8-hour day. So we'd like to push that farther if we can.
Hi.
Hi, James.
You mentioned that your guests, they can stay as long as they want during the day. And I was just wondering, like, since the pandemic has been, going on, have you had to modify your numbers or modify the time that your guests could spend in your space?
Well, that's a great question. And boy, I'm glad you asked it, because I should have said this at the very beginning. We have been operating virtually in our living room. So there is a way that anyone who is in crisis can access the living room, and then they are invited to go into a Zoom meeting with a peer or some peers. One of the things that happens in the living room is sometimes you talk to one person, and sometimes you talk to two people, and sometimes you talk to another person in crisis. So that kind of virtual environment, which we all had to learn 18 months ago, has actually turned out to be a really rich way to provide living room services. And I think as we move forward and we begin to work together once again in person, we might want to keep this virtual capacity available, because some people who are in crisis are afraid to leave their homes, as you know, and some people are not feeling well. And I think that actually we've now learned another way of working that's really valuable.
Other folks?
Yeah, and I was just wondering, can you speak to your work with the Skokie Police Department and kind of what the living room has done maybe to help alleviate some folks that might be going to the jail instead that
Sure.
came to the living room?
Yeah, thanks for asking that, Patty. Our relationships with the police, especially in Skokie, have a lot to do with our crisis programs and the fact that we have a lot of opportunities to have relationships with the police, because some of our clients sometimes need police services, and sometimes there are court-related issues, and therefore we are on very friendly terms with our police department and our police social worker. We also serve on committees and community task forces with the police and the fire department. And that, I think, is almost as valuable, because then we have a chance to talk about what our first responders are dealing with and how we can be helpful. A third important aspect of this relationship is that people in crisis sometimes have repeated crises. Sometimes people have one crisis and that's pretty much it. Other people who may be more anxious or under-resourced, or their circumstances are really difficult, may have repeated and frequent crises. And that's an opportunity for anybody, including our police and fire departments, to orient someone to our living room. So I think it's important also to talk about our partnership with the library. Lots of our clients are not necessarily wanting to come to a community mental health center to receive care. So we sometimes work out of our Skokie Public Library to offer groups and opportunities for people to learn about us. So the library is another important partner. And I think it's kind of a web of relationships that helps to hold this together. And it's something that we'd love to do in Evanston. And that's where I think you all come in, because you represent some of those organizations, and you certainly know the city personnel who would be very, very important for us to listen to and learn from.
And what do you see as the kind of the advantages of pairing the living room with the alternative 911 response approach that this committee is considering?
Well, one of the things that I think I shared when we met, and boy, it was a long time ago in June, was that I think mental health and behavioral health crises, as you know from our experience, can almost always be handled by the sort of response that we provide. So if we can get someone in crisis to a program like our living room, in Skokie, after 10 years, 99 out of 100 people do not go to an emergency room. They are not arrested. They do not require a level of care that could take resources and energy away from important city resources that really need to be attuned to higher levels of need and crisis. So I think that there are a couple of advantages. One is that we can talk to people sooner. We can help them settle down. We can also orient them to the really rich environment I keep talking about in our area that has many, many ways to respond to our individuals who are in crisis or who are in need. So maybe they don't know about Impact. Maybe they don't know about peer services. Maybe they don't know about Turning Point. But the more people who are involved in something like a living room program, the more likely these individuals will be to seek out care maybe on a regular basis and become clients. A third issue that is really important, and I didn't mean to jump over it, is some of our guests have lost insurance, for example, or lost jobs, and they need to apply for Medicaid. And that's a pretty complicated beast. So we have trained individuals who can help with that. And I dare say that there are people on this call who are also really good at that. You know, we haven't talked to the Moran Center about what we could do in common, but we'd want to. And that's something, again, that's just really important for me to stress, is that we by no means want to do this by ourselves. We'd never try to do it by ourselves. And I think the possibilities are really exciting.
So how many staff people are in the living room on a regular day, and are some are clinicians versus some are peer support staff, and could you talk about that?
Sure. And maybe Noi, this is a great time for you to talk about the personnel.
Sure, yeah. So on a particular shift, we could have at least one clinician and between 3 and 4, 2 or 3 recovery support specialists. And the shifts, as Ann mentioned, are from 12 to 8, and the staff are in those shifts the entire time. Sometimes we have folks who will call in sick or want to come in later, but there's always at least the 2 recovery support specialists and the clinician on site.
Mm-hmm.
And our clinicians are master's level folks. Some have licenses, some don't, but we're working on them. And our recovery support specialists have at least a bachelor's degree and or working under CRSS.
Another thing that I've talked with Patty and Maureen about is I'm really interested in this peer workforce, and wonder if there aren't adults in our Evanston community who have been able to achieve some recovery through mental illness or substance use or difficulties, who could become leaders in this kind of program. The peers who do this work are really inspiring and inspired, and they love it. And I think it's a great opportunity for us to think about developing that kind of program.
Yeah. And so for most of the guests who come to the living room, they find the living room sort of themselves, in the sense of a community partner refers them, or they heard about it, as opposed, for example, to a crisis team of some sort bringing them there.
Right. 60% find their way to the living room. 40% have some relationship with Turning Point.
Okay.
And we're kind of getting in the weeds, but I think this is something that you would want to know about, because we don't charge for this service, because it's grant funded, and because people are in crisis. It's interesting to think about the constraints of information we might have about these individuals. You know, if you're really upset, the last thing you want to do is tell us your address or how many children you have or whatever. And so this is something that I'm really open to thinking more about, because gathering data is so critical, and yet our guests are in crisis. So I think it's important to just keep thinking about follow-up, for example. How do we really track how people are doing? Because for the most part, I think it's fair, Dan and Noi, to say that when a guest leaves the living room feeling relieved, they also feel kind of done with the crisis. And so getting a call in 2 or 3 days to say, how are you doing now, is kind of like a rear view mirror irritant. And I think this is something that we'd love to think more about, so that we can gather important information.
given what you know about the Evanston community, and I'm thinking geographically, where would you think a good location for an Evanston living room would be?
Well, I sort of dream of something downtown where we have access to public transportation, where people tend to hang out. But I also imagine another dream here while we're talking about this is perhaps some sort of van or mobile presence in the community where we could actually go have pop-up living rooms, and we could drive our van to a place that maybe the police or school districts recommend, not so much to therapize people as to educate and engage them in thinking about health and mental health. And so I think the physical location is one piece of this, but we're also really interested in whether we could have a mobile presence, sort of like a bookmobile, but for the living room.
Yeah, no, I like that.
You know, it's interesting that you mentioned that, Anne. My first public health job was on a mobile van. I was working in Cincinnati, and it was a public health outreach. It was an infant mortality intervention. And like every Monday we were in this neighborhood, every Tuesday we were in this neighborhood, you know, and that actually worked out pretty well. I don't know how that would be on the mental health side as opposed to like pregnancy screening and, you know, prenatal care, but I mean, it would give us more opportunity and also options to see where there's demand as well. So we got a lot done in a 35-foot mobile home, I'm telling you.
Right. And you know, I grew up as a child therapist in Oak Park, and we did an awful lot of good pairing up sometimes with the police department who did fingerprinting, sometimes with the School of Dentistry from Loyola who checked people's teeth. You know, there are a lot of ways for us to join together, I think, with allied services to actually offer something to the people that we might be visiting. We had a van, actually a truck, I guess, Noy, come full of dentists one day at Turning Point. And I can't remember how many people we saw, but you know, what a wonderful resource for this group of individuals who have so much difficulty with dental issues.
And actually, that's a wonderful example of how we worked and partnered with Impact, because that was a resource that Impact shared with us.
You're right.
To the parking lot. Yeah.
Kudos to Patty.
And if I could jump in, that mobile sort of pop-up store is an idea that's being used successfully in Chicago in police diversion programs for people with substance abuse issues. In the Pulaski corridor, which is one of the largest open-air heroin markets in the world, there are agencies banding together with the police to do pop-ups just to bring the message to people so they know where the service is. It educates the police and the community at the same time, and the staff enjoy it. But and one thing, while listening to the conversation here, there are probably some good sites in Evanston to do that strategically. Like I'm thinking of the park next door to Albany Care. Always people doing a pop-up there where you give something away, like you know, something trivial but important to people, so that they get to know what a living room is, who the people are. It wouldn't just be helpful for the people living at Albany on that particular day, but if over time, if you know Albany Care, a large number of people move through that facility, in and out of hospitals and the nursing homes and the streets. And if you can find sites like that where you can get to those people who are high risk and likely to be using those 911 resources, that pays off over time. And you get to know the streets better, and through those people you get to know other places where you could be useful. A pop-up would be useful.
And Dan's a veteran of the outreach community, so you and Maureen could do the training for us.
Love to do that.
Yeah.
It was a very formative experience for me. I remember it very clearly.
Yeah.
Yeah, you know, part of my history was working at Thresholds, where we did develop the mobile assessment unit, which was a street outreach for people who are homeless and have a serious mental illness. And that was just going to certain spots and cruising them and eyeballing people and watching them over time. And finding the day that they needed help and wanted to take that step and being there. I think it was Eleanor was saying, do all the people have to come to the living room? Yes, that's the model that we've grown up with. Would it be effective to move that out in the community? You know, make other walk-in places also a place to access the living room, create new pathways? Yes, that's what we want to do. And the grant we've been waiting to hear about, which just last week we got final word about what our funding will be for FY22, fiscal year we're already in. We still don't have a contract yet, but we did learn we'll be fully funded, so we'll be able to execute some of those steps that we were envisioning, those ways to build alliances out in the community where we can create these new pathways into care. And Ann makes a very good point. You know, usually a small number of people are responsible for a disproportionate share of emergency services, 911, emergency rooms, inpatient care. It's a small population that uses a lot of it. I know personally, I have some good friends who are care coordinators for some of the managed care organizations. Blue Cross Blue Shield is the main one. And they have people on their caseloads that they're trying to manage their insurance care for, who, you know, have 40 hospitalizations a year, 40 times they're, and very often every time an emergency room is involved episode, and police and fire department are very often helping people find their way there too. So, you know, making those kinds of links, you can, you know, tap into that stream of people who might want to do something, take an alternative if we make it sweet enough for them.
Do you want to say a little? I was just going to ask a little bit more about the grant that's just come through. So, what is that for? More than a living room type activity, or what?
That is to besides even before the living room, Turning Point was a crisis care provider for the state of Illinois Division of Mental Health, and that's to be available to people who are unfunded and in crisis. They get the care even though they don't have a way to pay. That old arrangement ended on June 30th, and a new program called 590, which is a program number for what they're calling crisis systems, is being funded. And that expands the funding greatly, like gives us more resource and lets us use the money for things that will build those pathways, like collaborating with police departments, fire departments, being mobile, having the cars, the equipment, the training to go mobile, and being available more hours and more days. Even before 590, Turning Point had successfully received an expansion to their living room grant that helped them to go from 5 days to 7 days. And the same is going to happen for crisis. Crisis we've been able to staff it for a certain number of hours a week, and then just have a phone answering service for the balance of it. And now we're going to expand that in-person response as we grow, hopefully to 7 days a week. I mean, the ultimate goal is to have staff available 24/7, 365,
Mhm.
like the police departments.
Mhm.
But you know how big the police departments are. It's nowhere near that size of a grant, but it's enough for us to do some significant growth during this fiscal year, probably the next couple of few years. And actually, you know, the greater challenge now that we've got the contract is going to be finding people who want to do the work and training them and getting them on the front line. That's going to be a pretty big
Yeah.
challenge for the next several months.
Kristen, I cut you off on a question.
Oh, I just want to clarify, this is adults only, right? Over 18? Have you
Yes.
guys ever, I know it makes things more complicated, but I'm thinking about particularly like high school age students and whatnot. We work a lot with the schools, and when students go into crisis in school, and ultimately that a lot of times leads to the emergency room and hospitalizations. And so I'm just curious if, well, one, I don't know if it exists anywhere, because we talked to Joslin Center too, and it's adults only. But if there's any, you know, talk or thoughts about people under 18.
Dan, do you want to talk about the funding part of that?
Oh, yeah, the funding from the state of Illinois 590 is adults only.
Yeah.
That said, the under 18 services are done by Healthcare and Family Services through Medicaid or through the CARES system, which funds people in crisis. That's done on a person-by-person basis. So to some degree, Turning Point's had experience with working with under 18 and younger, but it's not the same grant. It's not even funded by the same part of the state. Our 590 is DMH and the other is HFS, but I think we've talked about it. The executive team at Turning Point's talked about it. And I think where we want to grow is to be a full lifespan kind of crisis program. We're going to have to take that in steps, and part of it's going to be merging HFS oversight and management with DMH. I think they'll want to go that way, but they each have their own mandate.
Yeah.
Getting them to work in the middle is going to have to happen at Turning Point and side by side. So, but we'll, I think, do as much as we can get away with without getting in trouble. Because all those young people grow up to be adults, hopefully, if things go well for them. And this will be a definite week. So working with schools, not out of the question as far as I'm concerned for the next year.
Well, and why, okay, I'm a little bit out on a limb now, but why couldn't we have a living room affiliation with the Moran Center and do something out of that location that could be related to Medicaid funding or Evanston funding? And it could be another part of the pilot. I think it would make sense to think about sort of taking 18 down, not from 0 to 8 years old, but more like, 18 to what, 14, 13. And to think about how we could begin to push those boundaries and show HFS that this is a really organic and synchronous way to let a living room grow.
I can add, I think what we know, what we've learned about folks at this age range, that they don't come to you. You have to go where they're at.
Yep.
So we partnered with the Skokie Public Library a couple of years ago to do just that, where we had these let's talk about it groups, where we had a mental health clinician and a librarian be available to just answer any kind of question that these kids had about mental illness or what's going on around the world. And in a way, it was sort of their crisis. It was sort of at that level that we were able to be and support. And I think that's sort of a first step towards a living room for this age group.
Right.
So interesting. And I guess I wanted to ask Kristen, when you think about a living room that would be responsive to teenagers, do you think that it would be best like inside the school or outside the school at a different time of day, when school, after school, like where, if you were going to make it, with unlimited resources, when would you do it and where?
Off the top of my head, I would think about it more, but off the top of my head, and I'm speaking specifically, the clients that I'm used to working with and whatnot, I think it would need to be outside of the school. Oftentimes when they are in school, that's part of the crisis, or contributing to what's going on is something within the school. And so, but Evanston obviously only has one high school. And so around the school or close to the school, I'm also talking with some social workers and administrative staff at ETHS about like a crisis response like team, and what that might, including people from outside of ETHS from different organizations, and how to respond when there are crises at school. And so, obviously they can manage to a certain degree while they're in school, depending on how escalated or, what the actual issue is. But I think what we've learned through the summer programming that we've had here is that once you get out of school, then you have all of this time. And if there's a lot of things going on, or you can't be in your home, or, different things like that, I think that the evening time is really crucial before somebody, may go to bed and whatnot. And so we've had them from 6 to 9, Monday through Friday all summer. And a lot of stuff has come up then, and we've stayed till 10, 11, whatever that is. So off the top of my head, I think it would be outside of school, but probably close to school and in the evening times, at least during the school year. Yeah, but I think, as we've said, we have so many organizations, right, that whether it's the youth and young adult outreach team here in Evanston or that have existing relationships with kids that could get them there, that they have, trust and things. I mean, really, the community centers over the summer have somewhat been like a living room that isn't always just for people in crisis, but crises have occurred while we've been there. And so, but it was like a drop-in center. And so that's what I'm thinking when I'm thinking through for, high school age, potentially even middle school age and things like that, is a place where people can go that is safe, that they can talk to people, I think peers and, clinicians alike. But yeah, that's kind of where off the top of my head.
So it's so helpful, this very long summer of trying a million different things and, just figuring out what kids are responsive to. And we have a wealth of information. And it's really interesting to me, to think about the ways in which the structures of the school, recreate a lot of what happens in the community, right? There are school safety officers, there can be police, there's a lot of social workers. So there's a lot of, I think sometimes, I don't know how much of that kind of like chilling out time happens inside the school, right? And so, and then at the end of the day, all of that comes undone, like whatever structure that created, comes undone. So it's interesting to think about what would be the right way to do this for teenagers. I'm not sure that just doing the same thing we do for over 18 would be the right thing. I think the drop-in component has been so important this summer, but it might be a good continued conversation offline for the folks from Turning Point and you guys to kind of debrief that, because it's live action, right? It's still happening.
Yeah. And I just think, and then I will end it, but we all obviously know, I think the younger that we can kind of like destigmatize or provide resources and all of that, maybe there won't be as many issues as they're 18 and older. And so, most of my clients honestly right now are 18 to 26, and so they are above that 18, but our other programming and whatnot, and all of the summer kids that we work with all summer, you just see how valuable it is. And then I think how much it opens their eyes to that it's okay to ask for help and to reach out, and that just makes such a difference once they do turn into adults. And but definitely would love to talk moving forward.
And that's why I think, that mobile capacity might be really interesting to get to neighborhoods and do something fun, not therapy, and have conversations that could lead to other sorts of decisions, and just kind of destigmatize ourselves a little bit.
Well, a lot of great potential and really exciting ideas, I think. Any other issues, questions, comments from committee, or Anne, any other ideas you have for us?
Oh, I have thousands of ideas, but I think these are the main ones. And I want to say again, it's really wonderful for us to have the chance to talk to you about this, to think about ways that we can, work on our flexibility and think about what kind of skills we can bring. And I do really want to emphasize that at Turning Point, we always try to say yes to opportunities. We're sort of not really anxious to own anything or control things or make things go our way. We really are interested in learning from one another. And I think something that I didn't say is that about 10.5 years ago, our living room at Turning Point began following a series of focus group meetings where we literally took a group of first responders, a group of people from the hospital, a group of librarians, a group of teachers, a group of parents, a group of community members. And we said, what do you need? And we built our living room program in response to what they told us. And that gets kind of retuned every year or so. And it might be a way to think about beginning a program in Evanston, because I think there are many similarities, but there are probably just as many differences. And we really are open to hearing what is needed. And we're pretty good at fashioning a program from what we hear. So I really appreciate that you took the time today.
Well, I think we as a committee have really been thinking that the idea of having a place where residents in crisis can go is just really missing in our community. Really a really important part of this giant puzzle that we're trying to solve. So it's really exciting to hear about the resources that we would have by working with you and your academy and all the good information that you could share with us from your 10 years of experience. So I think really exciting possibilities.
Well, thanks. We'd be honored to be a partner.
Okay. So so committee will meet in another couple of weeks. Is that on your calendar? All right. Continue our conversations to figure out our next steps. And Anne and Dan and Moy, we really appreciate your being with us this afternoon. And we will be in touch, I'm sure.
Thank you. If you have questions, you know where to find us.
Right. Great. Okay. Great.
Thanks for a great